Hello everyone, welcome. Today we are learning about anemia in general, its clinical effects, morphological types, and laboratory diagnosis. Anemia is functionally defined as insufficient RBC mass to adequately deliver oxygen to peripheral tissues. Three parameters are very important for the practical purposes for the identification of anemia, and that are hemoglobin, hematocrit, and RBC count. WHO defines the lower limit of normal for hemoglobin to be 12 gram per dl in women and 13 gram per dl in men. Let's understand the mechanisms by which anemia occurs. When hemoglobin content is decreased, like in nutritional deficiency or acute blood loss or aplastic anemia or any abnormal variant of hemoglobin that is interfering with the normal function of hemoglobin. Second is when there is a increased need of the body. Example is when hypoxic conditions are there. Oxygen requirement of the body is relatively increased. So there is a polycythemia. But if person has a normal hemoglobin in that condition, then the person is defined as anemic. Third is chemotherapy induced, like certain cytotoxic drug that interfere with overall erythropoiesis, and this leads to anemia. Let's understand the clinical effects of anemia. First and important is pallor, and it is markedly seen on the mucous membrane of mouth, conjunctiva, lips, and nail beds. The skin of palm become pale first, and if hemoglobin decreases less than 7 gram, then creases of palms also become pale. Alopecia is seen in pernicious anemia. Nail become brittle. In chronic iron deficiency anemia, nail become concave instead of convex. Chronic leg ulcers are seen in the sickle cell anemia and hemolytic anemia. Headache, vertigo, faintness, tinnitus, drowsiness, muscle weakness are also seen. Glossitis and atrophy of tongue papillae seen in pernicious anemia. This is the chart about how we evaluate the basic laboratory test in the case of anemia. The first is we see that anemia is associated with other hematological abnormalities or not. Abnormalities like thrombocytopenia or any abnormal leukocytes. If answer is yes, then consider about aplastic anemia, leukemia, or other malignant marrow disease which can be identified by the bone marrow examination. Pancytopenia can be secondary due to hypersplenism. So, if the answer is no, then see for the reticulocyte response. If reticulocyte count is increased, then anemia is probably because of the peripheral destruction of RBC. This is because blood loss or hemolysis. And if reticulocyte count is decreased, then anemia is due to impaired RBC production at the bone marrow or maybe due to ineffective erythropoiesis. If the anemia is associated with reticulocytosis, then see for the any evidence of hemolysis or not. Hyperbilirubinemia is a marker of increased heme catabolism. Also increase serum LDH, increase excretion of hemoglobin. These all are marker of hemolysis. And if low reticulocyte count is found, then analysis of the RBC indices are helpful like MCV. And according to MCV, anemia can be divided into three groups. Microcytic, when MCV is greater than 100 femtoliter. Macrocytic, when MCV is less than 80 femtoliter, and normocytic when MCV is ranging between 80 to 100 femtoliter. Peripheral smear examination is important for the dimorphic anemia, megaloblastic anemia, sickle cell anemia, and other anemias where morphological characteristics are very important. Example are when there is a leukoerythroblastic picture like teardrop RBCs, nucleated RBCs, early white cell precursor, or any abnormality in the platelet shape are seen, then it suggests the bone marrow infiltration. When RBC agglutination seen on peripheral smear, it suggests the cold agglutinin. Abnormal red blood cell type like spherocyte, cystocyte, acanthocyte, sickle cells can be identified in the peripheral smear examination. Now we try to understand the different anemia by the case-wise approach. The first case is 20-year-old male present with easy fatigue and weakness. On examination, patient looked pale and weak. Laboratory investigation shows hemoglobin is 7 gram per dl, MCV is 120 femtoliter, WBC count 3400 per microliter, platelet count is 1,20,000 per microliter, reticulocyte 0.7%, and peripheral smear examination shows hypersegmented neutrophil and macroovalocyte. So, from history and physical examination, this looks like a case of anemia. Now, when we focus on the lab investigation, hemoglobin is decreased markedly and MCV is increased. It is 120 femtoliter. So, it is a macrocytic anemia. Macrocytic anemia are divided into mainly two parts. First is megaloblastic anemia and second is non-megaloblastic anemia. To identify which type of macrocytic anemia patient has, the peripheral smear morphological examination is the most important. Most valuable finding to identify megaloblastic anemia are neutrophil hypersegmentation when lobes are more than 5 or at least 1/6 lobe neutrophil are found in 100 cell examined. And second is macroovalocyte. Macroovalocytes are the oval in shape with a reduced central pallor, and RDW also increased means RBC anisocytosis are also increased. And neutrophil hypersegmentation persists for an average 14 days after the institution of specific treatment. In bone marrow examination of megaloblastic anemia, marrow is seen cellular and hyperplastic, and there is characteristic megaloblasts are seen. Megaloblasts are large in size having delicate nuclear chromatin, which is also called the sieve-like chromatin, as compared to the denser chromatin of normal normoblast. The nuclear immaturation is quite remarkably seen in the orthochromatic megaloblast, where cytoplasm is very mature and pink in color, where nucleus is still immature and sieve-like chromatin as compared to the condensed and pycnotic nucleus in normal orthochromatic normoblast. Leukopoiesis is also abnormal. Giant metamyelocytes are seen. Their nucleus and cell size both are enlarged. Megakaryopoiesis is less affected, but if megaloblastic change is severe, then megakaryocyte number may be reduced and some nuclear abnormalities may be seen. After it is established that the patient has a CBC and morphological feature of megaloblastic anemia, then first determine the cause of it and identify if this is due to vitamin B12 deficiency or folate deficiency. The investigation of choices are serum vitamin B12 level and serum and RBC folate levels. RBC folate level is a better index than the serum folate level because serum folate is labile parameter and more fluctuation in levels seen after the consumption of folate containing food. Other investigation like serum homocysteine, serum methylmalonic acid are useful when the initial assays are not matching with the clinical and hematological findings. Rare hereditary disorder known as thiamine responsive megaloblastic anemia is also a cause of megaloblastic anemia. And copper deficiency and adverse drug reactions also the causes of megaloblastic anemia. Main drugs are associated with megaloblastic anemia are hydroxyurea, chemotherapeutic agents, anticonvulsants, and ART drugs. Second is non-megaloblastic anemia. It is a macrocytic anemia where RBC precursors are normal and without any changes of megaloblastic anemia. Macrocytosis is usually mild and MCV is ranging between 100 to 110 femtoliter. Here are some causes of non-megaloblastic macrocytic anemia. First is alcoholism. Macrocytic anemia are seen in heavy to moderate alcohol drinkers. It is not known how alcohol is affecting the bone marrow, but the macrocytosis can be reversed within 2 to 4 months if alcohol is restricted. Second is liver disease. In liver disease, mild macrocytic anemia is seen. It is associated with thin macrocytes where surface to cytoplasmic ratio is increased. Increased surface area is due to excess incorporation of membrane lipids like cholesterol and phospholipid. This give characteristic appearance of target cell. Third is after the blood loss or hemolysis. Erythropoietin level is increased and this leads to premature release of marrow reticulocyte into the peripheral blood and this gives rise to mild to moderate macrocytosis. Other causes are myelodysplastic syndrome, myeloproliferative neoplasm, aplastic anemia, congenital dyserythropoietic anemia type 1, type 2, hypothyroidism. The second case is 25-year-old female present with weakness, faintness and fatigue. On examination, she looks pale and weak. Hemoglobin is 6.5 gram per dl. MCV is 70 femtoliter 70. HCT 21%, RTW 17%, WBC count 5600 per microliter, platelet count 5,20,000 per microliter. In peripheral smear examination, microcytes, elliptocytes, and thrombocytosis is seen. In clinical and laboratory findings suggest it is microcytic anemia. Causes of microcytic anemia are first is disorders of iron metabolism, that is iron deficiency anemia and anemia of chronic disease. Second is disorders of the globin synthesis, that is alpha and beta thalassemia, HBE and HBC syndromes. Third is sideroblastic anemia. They are acquired, hereditary, and refractory anemia with ring sideroblast, and others are malignancies and myeloproliferative neoplasms. First, we see the iron deficiency anemia. The source of iron for hemoglobin synthesis is carried by the transferrin. Transferrin is a hemoglobin binding protein in the serum. At the storage site in macrophages are depleted from the iron and plasma iron concentration falls in iron deficiency anemia. When transferrin saturation is decreased to less than 16%, normal is around 20 to 40%, Then RBC production decreases and microcytic hypochromic RBCs are formed, and this is called the iron deficient erythropoiesis. Iron deficiency anemia are most commonly seen in the children and young women. And anemia of chronic disorders is usually seen in the elderly people. Now we learn the laboratory investigation of iron deficiency anemia. Peripheral smear shows microcytic hypochromic anemia, and other investigations are serum iron, TIBC, transferrin saturation, serum ferritin, etc. Among these, serum iron, transferrin saturation, and serum ferritin are decreased in iron deficiency anemia, and TIBC is increased. So, what is TIBC? It is total ion binding capacity. Ion binding capacity is capacity of the transferrin to bind the ion. So, when iron is decreases in the serum, the capacity of transferrin is increased to bind that ion. Evaluation of bone marrow iron store is a gold standard for determining the iron depleted state of the patient. Bone marrow aspirate is stained by the Prussian blue method, and hemosiderin that is intracellularly seen in the macrophages that are stained blue, and hemosiderin stored in the marrow graded from 0 to 6 plus. In iron deficiency anemia, marrow hemosiderin is absent. Disorders of the hemoglobin chain synthesis. They are thalassemias and other hemoglobin variants. Thalassemias are inherited disorders where one of the globin chain synthesis is affected. In milder disease like thaltrate, microcytosis and hypochromia are prominent, but anemia is mild or absent. And in severe disease like beta thal major and HBE beta thal, microcytic hypochromic anemia is very severe. In beta thalassemia trait, Manzer index is less than 13. Manzer index is equal to MCV in femtoliter upon RBC count in millions per microliter. So, if the ratio is less than 13, then it probably suggests a beta thal trait. Other findings are microcytic hypochromic RBCs, HbA2 fraction increase in Hb electrophoresis. In beta thalassemia major, microcytic hypochromic anemia, signs of hemolysis, nucleated RBC, extreme anisocytosis, poikilocytosis, and target cells are seen. Alpha thalassemia syndromes are due to the reduced alpha globin chain synthesis due to one or four structural gene deletion. First is silent carrier state. When one gene is deleted, it is hematologically normal. Second is alpha thal trait. When there is lack of two alpha globin genes, it shows mild microcytic hypochromic anemia. Third is HbH disease. When there is a lack of three alpha globin genes, it shows moderate hemolytic anemia. Fourth is homozygous alpha thalassemia. When there is a lack of four alpha globin genes, that is incompatible with life. Laboratory investigations for globin chain disorders. First is peripheral smear. Microcytosis and red cell abnormalities like sickle cells are seen on the peripheral smear. Second is Hb electrophoresis. Increase HbA2 and increase HbF indicates beta thalassemia variants. Alpha thal are not associated with increase in HbF or increase in HbA2. They are usually not detected by Hb electrophoresis except HbH disease. They are mostly the diagnosis of presumption by excluding iron deficiency anemia and beta thalassemia. Genetic testing are available and important for the confirmation of a globin chain disorder and prenatal diagnosis. Sideroblastic anemia. They are acquired and hereditary. They show dimorphic population on smear, microcytic and normocytic. Impaired heme synthesis leads to retention of iron in mitochondria, and in bone marrow aspiration, many nucleated red blood cells with iron granules surrounding nucleuses are seen, and they are called the ring sideroblast. Normocytic anemia. Values of the MCV are normal between 80 to 100 femtoliter. Causes of normocytic anemia are anemia of chronic disease like kidney disease, liver disease, or endocrine origin. Other is hemolytic anemia or anemia after acute hemorrhage. They may be normocytic or slightly macrocytic. Pure red cell aplasia, where reticulocytes are decreased markedly. Normocytic anemia, reticulocytopenia, leukopenia, thrombocytopenia suggest intrinsic marrow disease like aplastic anemia, leukemia, myelofibrosis. In peripheral smear, morphological changes are seen like nucleated RBC, teardrop cells, immature leukocytes, and large platelets. Congenital dyserythropoietic anemia type 2 is the most common and associated with normocytic anemia. So this is in general description about anemia. Hope you like it. Thank you.